Physios in the audience who work in the acute sector as well, you're welcome to put your hand up if you would prefer to respond to this question. I'm going to ask it to our panel first, and unfortunately for you, Morag, you are who I am going to target it to, unless a physio in the audience puts their hand up. All right, so how do we persuade our executives who are slashing allied health KPIs for the need for intensive input? We struggle to get once daily allied health. Now, I know a lot of hospitals probably feel that way. I'm not going to put my own hospital under pressure, Michael, but we are incredibly fortunate that our physio department has realigned how it works, and hip fracture patients get allied health twice a day, 7 days a week, but that's taken years for that to be achieved, and I know that that's not normal for many hospitals, but that's been enlightened physios driving that agenda. Morag, comments?
I would say I'm not sure I'm the best person to ask, because so many years ago management came and told us that we needed to cut our physio department, and where would we like to cut them from? And I said, what would you say if we said we needed to cut it from management? And I was told, be very careful, there is the door. So I think all I can say is I think you need to use the evidence and take the evidence, and if you can get the whole department and the multidisciplinary team on board, then the more voices you've got saying the same thing, then it'll carry more weight. But I think you've got to really try and use the evidence to, and if you've got any local evidence to show that you're doing more, like use the hip fracture registry data. If you've got evidence to show that you're doing poorly on the mobility indicators compared to other hospitals, then use that, take it to them and show them and say, look, this is our hospital and this is, other hospitals. So what are we going to do about it? And we need some assistance. If we don't have staff, working on the weekend and we're operating on a Friday, then you can't get people up on day one if you don't have anyone working on Saturday. So that would be my comment.
Useful information. Nobody from acute sector wanting to comment? Jack?
Do I need a mic?
Probably. Well, no, do, because people are online.
Yeah, sorry. So I'm clearly not a physio, I'm a dietitian, but our site has had a business case, and we've over doubled our numbers in the last 3 years, and I think we've effectively had a reduction in our physiotherapy FTE over that time. And so at the moment we've got some grants in to try and look at better use of physiotherapy assistance, and it was interesting to see that the data's there as well. So I think we do need to be agile and look at how we can use all of our workforce and be cost effective, but at the same time deliver that care. So it was really nice to see that there was some evidence that's showing in terms of assistant staff. So
yeah, good point in terms of better use of allied health. And of course, we forget that nurses are perfectly capable of mobilising patients as well, and frequently do. So we're thankful for that as well. But I think we recognise it's a challenge, an ongoing challenge, and Morag's point about using the data for your business models is a good way to go. All right, next question is for... Oh, Louise, do you want to comment?
Yes, I was just going to comment. I know I'm a paediatrician, but I have been on the board of Sydney Children's Hospital Network for many years, and I've been involved in developing clinical services in paediatrics. And I was going to highlight the importance of cost effectiveness data and also the voice of people with lived experience. Now, that takes time and energy to organise, but even being able to hear the importance of that at the executive level is important. But data and dollars tell lots of stories. I agree with the concepts about if there is going to be some creative use of other staff, all of those things, but being able, not meeting required standards and actually having a poorer outcome than other hospitals, other services, is also speaks enormously. But you need to be creative, and that takes time and energy, and you may well not have as much time and energy, so you're so busy meeting the needs of people with your reduced staffing numbers. So I really get it, because I understand that in my own area of work.
I think the important point about the experience is also good. Certainly the registry has piloted patient-reported experience measures, being able to provide feedback to executive about what the experience for our patients has been, will be important. We hope that many more sites will take up the opportunity to get people to complete PREMs at the point of discharge from hospital, so that we can actually get some constructive, or hopefully constructive, feedback from patients and families as to what the experience of being in hospital with a hip fracture is like. Louise, the next question is targeted at you from Kathy Sherrington. So thank you, Louise and family, for your generous and open presentation. This time we're asking you to move into the residential aged care. Any thoughts on how we can advocate for better rehabilitation in aged care facilities?
Oh, I've been reflecting on this quite a bit, and thank you to the other speakers who spoke well and really showed great evidence. I think that's one of the first steps is actually having that evidence, including the registry, but all the the Cochrane reviews and others. That is actually really helpful. But we're still looking at dollars. We're looking at society that may not necessarily put as much investment in elderly people as we think is important. And yet that's a false economy, because an older person who lives a good life and not being unwell but enjoying life is actually a cost benefit to the broader community, not just to themselves but to their family and friends. So I know that, you know that. How do we tell the story? I think being able to give your data very clearly to other places, being able to compare things like I don't know if being able to compare yourself to other institutions who are doing better in terms of outcomes will be important. The voice of people with lived experience, the voice of families, the voice of elderly people themselves, really important in all of this. I don't have a magic solution, but those sorts of approaches are what are needed for improving care in other places. This must be the case here. And we certainly, it really does help if you've actually got private money, and that's what my father had. That helped him. But most people don't have that sort of amount of income. We need to be able to provide it for everybody. It shouldn't just have to depend on what your hip pockets are like. So I don't have an easy solution, but anyway, I want to support you in what you are doing, because it sounds, the work that I've just heard is just really impressive. I just want lots more people to hear it. Thank you.
And the panel want to add to that. It's a really important area.
Yeah, I think we've been using patient stories to try and educate funders, but I think we need to probably start doing a multidisciplinary think tank about the whole health system and how best we allocate resources, because it's very siloed and professions fight for their little bits, their little strands, and there's just a lack of connection. So I think we've got to be like, organisations that are advocacy-based, that are multidisciplinary, are probably where these conversations need to happen.
Yeah. Morag pointed out to me that Maria Crotty led a citizens' jury where they had a sector of members of the general public talk about the value of rehabilitation after hip fracture. So Maria Crotty led, in residential care specifically. So she led a trial that showed that an outreach program could increase mobility, but it was really not cost effective sending geriatricians and everyone out into residential aged care. They did a citizen jury with the general population, presented all the data, really expected people to say, well, no, that's not where you should be putting your money, it's so expensive. And the overwhelming response was, yes, people in residential care have the right to rehab and should be receiving it. And so that's published, that can be provided to people. And just one other thing, we're piloting. So from that trial, they had an outreach program of geriatricians and everyone going into residential care, improved mobility, improved quality of life short term. We're now piloting an e-community of practice where we've got representatives from each of the aged care of our enrolled aged care facilities. We've got, I think, 8 or 10 aged care facilities. Most of them are physios, and our Flinders Uni team are training them of how to provide better post-hip fracture care in the residential aged care facilities, and then they're implementing a quality improvement program at their sites. So through using education of care staff and all the staff in their facility to try and get better hip fracture care.
I think the phrase that was used for Maria Crotty's jury in terms of the residents is they felt it was a basic human right to be able to maintain mobility. So that was fairly strong language despite limited evidence of effectiveness, but the message is there. All right, another question. I'm going to start with Morag with this one. So how do we overcome barriers for rehab being offered to patients with dementia? So just for those of you who do not know the ins and outs of the hip fracture registry, there is huge variation across hospitals in terms of who gets access to rehabilitation. So people coming from the community with existing cognitive impairment, we have some hospitals where 70% and more get referred for rehabilitation, and some hospitals where we're down at 10, 20%. That is huge variation. What we've been less able to say as a result of that is, does it lead to different outcomes? Morag, comments?
Well, I don't think cognitive impairment on its own should not be a barrier to receiving rehabilitation. And there is evidence to show that people with, and in a different study that I haven't published yet, but have looked at the data, we can see that people with cognitive impairment do improve when they have rehabilitation, so their functional independence measure gets better, the physical side of it, not normally the cognitive side of it. And so we do know that they get better. The issue is, and I did look at that based on their cognitive FIM on admission to rehab, and both the poorer cognitive FIM and the severe cognitive FIM, they all improve, but often to different degrees. And so I think cognition shouldn't be used as a barrier, but it is tricky when you have has no rehab potential. I guess that's the tricky bit, and I think sometimes that, I'll think about how I say this carefully, that can have to do with the skill and the experience of the clinicians, because if you have a very junior aged care training within physiotherapy degrees is quite minimal, and most of the learning is actually done on the job. And so the knowledge and skill level of physios who are, in their very junior years as a physiotherapist in working with people with delirium and dementia is probably quite low. And so I think it's important to try and make sure that we're engaging and training clinicians in the best way to work with people with dementia, and sometimes using, shall we go and get a cup of tea, or, oh, you need to go to the bathroom. Well, let's walk you there. Some of those other ways to move people around. And I think sometimes you do need to spend time with people and find out what makes them tick, and then to use that rapport and that relationship to encourage them. And this again becomes the difficulty with having the time to invest in that. And I think if we can get the evidence to show that receiving rehab improves outcomes, then we can, fairly strongly say that people should be given a chance. And it comes down to the human rights issue again, where there's a movement by people with lived experience of dementia, where they have a right to restorative and rehabilitative care. And I guess it gets a little bit more tricky when we talk about the severe end of dementia, where I think we have less evidence that there's improvement in that group, because often the studies are done in people with mild to moderate cognitive impairment.
So along the same line, another question I'll put to the panel generally, you can decide for yourself who wants to answer. So given cognitively impaired people are more settled in their own environment, such as an aged care facility, would early access to rehab out of hospital improve outcomes? So basically we give people one shot at it, and we give them one shot at it in terms of making our decisions very soon after surgical intervention, when, as the cognitively impaired people, 60% of them are delirious. We don't say you can go back to your residential aged care facility and we will revisit your rehabilitation potential 2, 3, 4 weeks down the line. That's the way our health system is set up at the moment. You're either ready for it and going to benefit at the beginning, or you don't get any at all. Comments on timing and place of rehabilitation for this population? Rik.
People with cognitive impairment to be able to be offered rehabilitation in the residential aged care environment where they know the staff know them, they know their routines, they actually have really good relationships and they know what motivates them. I think rehabilitation in a facility would be really ideal. It's just the delirium aspect that they struggle to manage, and it's interesting, Louise's story is really important. They often come back with delirium and there is not that clinical depth of skill to manage, and the interventions on offer aren't there. So these getting them healthy to go home and have their rehab would be ideal. There is always a case for some people, but it's generally those who are cognitively intact that often might want to go back to rehab later, and because that environment could suit them, because it's always going to be more intense. But yeah, with cognitively impaired people, we've just got to create the opportunities for them in their environments where they are comfortable.
With adequate resources to be able to do that, which we simply don't have.
Yeah, and I think Maria's study that Sue touched on, it did show improvement in short-term outcomes, but I think by 12 months the outcomes weren't different between the group that did have the in residential aged care outreach physio or didn't.
Which was partly because there was a lot of death.
Yes.
So, there were short-term improvements of outcomes, but, a lot of loss of people dying over the 12 months. So by 12 months, that wasn't significant. I think another thing that's really important in the residential aged care setting, which we're finding in this pilot, is the thing about discharge summaries. It's just even in, settings we're familiar with that are very high quality, we're not getting really good discharge summaries for care, for how to manage people post-hip fracture. And another really important point, I suppose, in good guidelines in hip fracture management in residential care, which we haven't touched on today, is the coordination by the staff in the care facility around pain management and pain recognition, and trying to get that timing of pain management so that the mobilisation is more likely to happen.
Yeah, a very good point. I'm aware of time. Oh, one question from a human actually speaking, I hope.
A question to Rik around the use of rehab in the home resources. Is it something that you see being used for patients who are coming back into residential aged care as an alternative to on-site physiotherapy?
We don't see any rehab in the home in residential because there are barriers about access to that program. There's lots of talk at the moment about that style of program. We haven't talked about the home aged care space that in a year's time is going to be over nearly 1.3 million people will be receiving aged care services in the home, and those sort of rehab in the home, transitional care packages in the home, the access to that. We've always said that residential should have the same opportunities to get these services, but it's just not at the moment allowed.
Well, I think TACP is Commonwealth funded, and then so are nursing homes, so I think they would see it as double dipping. But post-acute care, they do go in and give...
Some, but not much.
I think it's a funding...
It's highly variable and state-based. Yeah. All right. I hope you will all agree that was an excellent opening session. Louise, thank you very much for giving up your time and